briefly. So our first speaker today will be Chris Geisler, who's a senior medical director at Travere, and he is joined by Jerry Appel, who is at Columbia University, and Yelena Drexler from the University of Miami, who are both preeminent nephrologists, and we're really glad to have everybody on board for this webinar today. Chris, I'll hand it over to you. And you're on mute.
Thanks so much, Laurel. My name is Chris Geisler. So I'm a community nephrologist, one of the medical directors at Travere. We'll spend the first part of today talking about the data supporting sparsentan's use in IgA nephropathy, and then we'll spend the second part of the lecture discussing with the panelists their management of IgA nephropathy. And so with that, I'll turn it over to Dr. Appel and Dr. Drexler to introduce themselves.
Hi, I'm Jerry Appel. I'm founder and co-director of the Glomerular Kidney Center at Columbia University, where we see about 3,000 patients with non-diabetic glomerular disease each year. The pathologist process 6,000 biopsies. And I can tell you that there is no disease, no glomerular disease that is more challenging these days and more exciting than IgA nephropathy, with so many new medications coming out all the time. And I'll pass it right on to Yelena.
Hello, I'm Yelena Drexler. I'm an academic nephrologist at the University of Miami in the Katz Family Division of Nephrology and Hypertension, where I also serve as co-director of clinical research at the Katz Family Drug Discovery Center. And I'm involved in clinical and translational research studies in glomerular disease. And my clinical focus is in caring for patients with glomerular diseases. I'm passionate about advancing precision medicine to improve the outcomes for our patients. I earned my medical degree and completed residency and fellowship training at Columbia University Medical Center, where I had the honor of training with and learning from Dr. Appel. So I'm very excited and thank the ISGD for the opportunity to speak to you today.
Awesome. Thanks so much, y'all. So without further ado, we are going to move forward and spend some time looking at the clinical data in support of sparsentan for the management of IgA nephropathy. Now, before we dive into those studies, I do want to spend a few moments just looking at some of the evidence and the guidelines on how we manage IgA nephropathy. And I think our view of IgA nephropathy has evolved, right? So certainly even when I trained, we were taught that IgA nephropathy was one of the more benign diseases. That was the good GN to get. We now know with newer data that probably nothing further than the truth, right? So first and foremost, when our patients are initially diagnosed, the majority of them already have about 50% of nephron loss at the time of diagnosis. So it's really important to focus on kidney-targeted therapy to preserve those remaining nephrons, in addition to thinking about immunosuppressive therapies. And so kind of thinking about that and this dual approach is really important. Now, the RaDaR database is what really made us change our minds on the prognosis of IgA nephropathy, right? So these patients that we typically considered at low risk in the past, they may have had about a gram or less of proteinuria, are actually at high risk of progression of disease. And we even know that about a third of the patients with about half a gram of proteinuria are still at risk for developing kidney failure within 10 years. So the UK RaDaR registry, which followed these patients out for quite some time, really did help set the standard of complete remission should be the goal for all of our patients with IgA nephropathy to slow that nephron loss. And based on that, that's where we get some of the KDIGO guidelines here, right? So the first and foremost goal is to prevent that GFR loss to less than 1 ml per minute per year so that we can prevent the patients from progressing to end-stage renal disease. We've seen different heat maps from the Pritchard group really showing that if your nephron loss or if your GFR loss is 3 ml per minute per year, almost all of those patients, regardless of age, do progress to end-stage kidney disease. Now, in order to do this, really the only validated biomarker that we currently have is proteinuria. And so the recommendations from KDIGO are to maintain the proteinuria less than 0.5 grams per day, and even ideally less than 0.3 grams per day to prevent that progressive nephron loss. And based on that, we also have the new KDIGO algorithm. And obviously want to highlight here the importance of simultaneous treatment, right, to really make sure you're aggressively treating these patients with IgA nephropathy. On the left, we have our immunosuppressant side, and we're going to focus today predominantly on the right-hand side, which is basically the kidney targeted side, or we refer to it sometimes as the foundational side, in trying to preserve remaining kidney function. And of note, obviously, lifestyle modifications are important, but we want to make sure that these patients are on an optimal foundational therapy. And in the guidelines now, that is suggested to be either RAS inhibition or a DIARA, which is sparsentan, right, as a first-line therapy to slow the progression of the kidney disease that's already started from the immunologic agents. So with that, we'll talk a little bit now more about sparsentan. And we'll start with looking at data from the phase 3 PROTECT trial. First and foremost, the indication for sparsentan. So sparsentan is an endothelin and angiotensin 2 receptor antagonist that's indicated to slow kidney function decline in adult patients with primary IgA nephropathy at risk for disease progression. And as I'm sure many of you all are aware, we now have full approval for this indication, and the drug's been available now for over 2 years in helping to manage patients with IgA nephropathy. One other exciting modification that we had here at the end of the summer was a modification to our REMS. So the first modification, and these are based on the totality of data from all of our clinical studies, as well as our experience with the drug being used in the community, but the LFT monitoring was reduced from monthly now to quarterly. So LFTs need to be monitored at the initiation of treatment and then every 3 months. One other notable finding was that the pregnancy testing requirement REMS section was removed. Now, obviously, because sparsentan is an endothelin and angiotensin receptor antagonist, women of childbearing age need to actively avoid pregnancy while being on the medication, but they're no longer required to submit monthly pregnancy tests to fulfill the REMS modification. Obviously, if pregnancy is detected, the drug needs to be discontinued immediately. Now, when we think about how sparsentan works, so it's a DIARA, a dual endothelin angiotensin receptor antagonist. And so it simultaneously blocks endothelin-1 and angiotensin 2. We know that when immune complexes deposit in the glomeruli and start the whole process of IgA nephropathy, both angiotensin 2 and endothelin-1 are upregulated, and these contribute to ongoing damage in the kidney. Now, for decades, we were very good about blocking angiotensin by putting patients on RAS inhibition, but we largely ignored the role of endothelin. And it turns out that endothelin is playing as large of a role, if not more so, in the damage that's occurring in the glomeruli. So by blocking both of these pathways simultaneously with a single molecule, with sparsentan, we're providing more kidney protection. And we're going to show the results of that in PROTECT and some other studies. But sparsentan has been shown to be anti-inflammatory, anti-fibrotic, and obviously anti-proteinuric, which we'll show here very shortly. PROTECT was a randomized, multi-center, double-blinded study using an active comparator. And so that was one thing that differentiated the sparsentan studies from other studies in IgA nephropathy, is that rather than going against placebo, sparsentan went against a max titrated dose of irbesartan. So in the study, patients were randomized in a 1-to-1 fashion to either receive sparsentan or irbesartan. The starting dose of sparsentan was 200 milligrams, and then at 2 weeks, as long as there were no issues, it was a protocol titration up to 400 milligrams. Irbesartan was started at 150 milligrams, and very similarly, at 2 weeks, it was a protocol titration up to 300 milligrams. And then the patients were followed throughout the 110 weeks. Of note, the percentage of patients that achieved that maximum labeled dose, 94% in the sparsentan group, 96% in the irbesartan group. So we're really comparing max to max here. So we're looking at sparsentan compared to basically RAS inhibition on its best day. The primary efficacy endpoint was the change in the UPCR at week 36. And then we'll also look at long-term proteinuria data as well as eGFR data. Now, here's the proteinuria data. And what we see is sparsentan in teal, irbesartan in gray. And you see a rapid and sustained reduction in proteinuria in the sparsentan group. So at week 36, there's a 48% reduction in proteinuria in the group receiving sparsentan from baseline. Now, keep in mind that prior to entering the study, all patients were on RAS blockade, and about 66% of them were on a max label dose RAS. So what we're seeing here is this 48% reduction is in addition or above and beyond what they were achieving on sort of what their standard of care was. Now, if we look at the irbesartan group, we also see a reduction, and some of that's probably because of that protocol titration, pushing people to max label dose. But we see that, that 14% still nowhere near the results that we're getting from the patients that were on sparsentan. And what we see with the sparsentan group is that effect, that proteinuria reduction, is sustained throughout the 110 weeks, whereas in the irbesartan group, that effect tends to wane, so that by the end of the 110 weeks, it's really only a 2% reduction. And again, some of that may be explained by the fact that we're ignoring the role of endothelin by only blocking the angiotensin receptors there. Now, recall that KDIGO recommends getting our patients to complete remission, and keeping in mind that our IgA patients are typically young, probably not fans of taking a lot of medications. We're looking here on the right-hand side at the patients who achieved less than 0.5 grams per day. And what we see is in the sparsentan group, we see about half of them, so that second set of bars there, got to that 0.5 grams per day, 51%. Now, if you want to be stricter and even move down and say, well, I want complete remission, less than 0.3, I want no proteinuria, we see that about a third of the patients on sparsentan got there. And contrast that with only about 11% of the patients that got to complete remission with irbesartan. So sparsentan had that rapid sustained reduction in proteinuria, and the patients were markedly more likely to get to complete remission when compared to a max label dose of irbesartan. How does that translate to GFR? Well, what we show here is, again, sparsentan in teal, irbesartan in gray. And we see that the decline in the eGFR was slower in the sparsentan group compared with the irbesartan group. And that benefit tended to increase over time. So at 1 year, the difference in the eGFR slope was 1.9 mils per minute per year. At the end of 2 years, when we're looking at absolute change in the GFR, that difference was 3.8 mils per minute per year. So we did have statistically significant slopes when we looked at the on-treatment patients. And we're seeing here, again, they tend to diverge. And so we are showing GFR preservation with sparsentan compared to a max label dose of irbesartan. Now, for our patients, I think eGFR and proteinuria may be difficult to understand, but they all understand dialysis very well. And so what these data here did is they used the eGFR slope and combined with the starting eGFR in the PROTECT study, so about 56, 57 mils per minute of the GFR. And what we show is by using the slope, we look at when the patient's likely to cross an eGFR of 10, about the time when we'd start considering dialysis, right? And so what we see is that for the patients that receive sparsentan, they have about 4.5 years longer off dialysis than if they were on that max label dose of irbesartan. Knowing that our patients are young, these are kind of critical time, right? This is time for them to continue to advance in their career, raise their children. And to me, importantly, I think when we're trying to keep people off dialysis, is buys them time in that 10 to 20 range where we can get them listed for transplant and hopefully even get them a preemptive transplant. Now, one other thing we compare here is just standard of care. So we took the standard of care arms from other studies in IgA nephropathy where the patients weren't on a max titrated dose of RAS inhibition and they weren't on a dose that was being closely monitored, right? And what we see there is that using sparsentan compared to those groups gives you about almost 7 years of time off dialysis. So again, by using the eGFR slopes, we're sort of able to project out what will happen to these patients. But I think these are powerful data in sharing with your patients that, hey, this is potential to really delay and preserve your kidney function. Now, as far as safety profile, the safety profile for sparsentan was very comparable to irbesartan, right? And so what we see here, hyperkalemia, hypotension, edema, dizziness, acute kidney injury. Of note, only 2 patients in the sparsentan group had to discontinue due to hypotension. And 1 did discontinue due to orthostatic hypotension. So overall, again, we're getting our patients in the high 90% to the max label dose, and it was well tolerated. Now, one other thing to point out is just what's really happening to blood pressure. So these are the blood pressure tracings. Again, sparsentan in teal, irbesartan in gray, and really we see an initial, slight reduction in blood pressure that's then stable. But when you look at these graphs, they really kind of overlie each other, right? We're not seeing any major blood pressure drop in sparsentan in comparison to what we see in the irbesartan group. So that leads us, and we're going to pick up this thread here in a bit when we talk about the Spartan study, but it's more than blood pressure that's causing that proteinuria reduction that we're seeing. And we're going to explore kind of what else might be going on. So kind of keep this in mind as we move forward and look at the Spartan study in a bit. But blood pressure is essentially identical in the sparsentan and the irbesartan group. So overall, and this comes from KDIGO at the top, the DR sparsentan is the only drug shown to have efficacy beyond the in-trial up-titrated RAS, right? So the only drug that went head-to-head with a max label RAS inhibition. And so we showed the significant reductions in proteinuria. We showed that the eGFR declined at a slower rate. And again, we showed that comparative safety profile compared to that max label irbesartan. So looked at a sub-analysis then of PROTECT, because again, thinking about KDIGO and thinking how KDIGO mentioned, hey, the most important thing to do is to get to complete remission, we wanted to drill down on that and show what happened to our patients in the PROTECT study that got to complete remission. This was a post hoc analysis, and instead of comparing sparsentan to irbesartan, we're now comparing a bit differently. We're comparing, did you get to complete remission or did you not? And so I'm going to show that data here. But just to reference, just to kind of orient you first, the dark blue line is the group of patients that got to complete remission, less than 0.3 grams per day. The lilac or gray bar are the patients that did not get to complete remission. And again, this is now treatment agnostic. So there were people in the blue group on irbesartan, but the majority, about 73% of the patients that got to complete remission were receiving sparsentan. But it's really interesting because what do we see here? Well, the dark blue group that got to complete remission, we see an initial dip in the GFR. But then what's really cool is over the 110 weeks, we see stability, right? So over time, when you're looking there, the total slope is about minus 1 mil per minute per year. So again, that's that physiologic change that KDIGO says we have to get to, right, in slowing. Now, the story is different and obviously much worse for the people that don't get to complete remission. Their eGFR slope, minus 4.5 mils per minute per year. So again, this clearly, kind of reiterates what KDIGO's already told us, what RADAR's told us, is the importance of getting to complete remission. And again, in this post hoc analysis, 73% of the people that got to complete remission were on sparsentan, 27% were in the irbesartan group, but complete remission should be our goal because we know it translates to beneficial GFR preservation. We also see that the group that got to complete remission, again in the blue, had much fewer kidney events. So one event over the course of the study, over the 110 weeks, whereas if you did not get to complete remission, 43 events. And of course, those events are increasing in the creatinine or decreasing in the GFR, obviously, or progression to end-stage kidney disease. So again, more data to show you'd much rather be a complete remission patient than a patient that's not getting to complete remission. So I think it's paramount that we do all we can to get these patients to complete remission, especially now that we have tools. And so that's just again here, just a little bit of a review. But from KDIGO, there's moderate certainty of the evidence that sparsentan does greatly increase the likelihood of getting to complete remission. And we showed the data there, just re-emphasizing the importance of getting to complete remission. Now, I want to go back and look a little bit at the Spartan study. So Spartan was a phase 2 study, and it's an open label, single arm study. And really this study is looking to explain why sparsentan works, right? And so again, this is work from Dr. Jonathan Barrett, out of his lab. But what they took here were de novo patients, newly diagnosed IgA nephropathy within 6 months that had never been on treatment, so could not be on RAS inhibition, could not have had systemic steroids within 6 months. And so really, if we take a brand new patient that I just diagnosed, put them on sparsentan, how well do they do? And why do they do that well, right? So that's the second part of this. It's a mechanistic study as well to kind of pair along with PROTECT to give us a little bit of answers. We already showed you the blood pressure changes were the same from sparsentan or irbesartan. So this study seeks to get at, well, why are we seeing those proteinuria benefits? What else is going on? And so we looked at a host of data here, and I'm going to walk through some of these. But in Spartan, when patients were screened, they got 200 milligrams of sparsentan. Then we're advanced at this after 2 weeks to 400 milligrams and are being followed. And this is actually still an ongoing study, so we'll have more and more data to present and even some additional data to present here at ASN in a few weeks. But the first thing we see is an even better reduction in proteinuria than what we saw in PROTECT. And again, some of that probably speaks to we're getting to these patients earlier. And so now by week 4, we see about a 62% reduction in proteinuria. And that was maintained throughout the 24 weeks, is basically where we have data to at this point, kind of continued to improve, almost hitting 70% at week 24. But the other interesting thing to mention is that the median UPCR at week 24 was 0.3. So we're getting these patients to complete remission. We're getting that nice reduction and getting them to remission. Now, because this was a small study, we were able to plot out how each of the 12 patients did. And what we see here is of the 5 patients who actually came in with a lot of proteinuria, greater than 2 grams a day, 4 of them had proteinuria reduction of more than 75% at any time during the study. We also note that almost 60% of the patients did achieve complete remission at any time during the study. And so again, reemphasizing the importance of getting to that goal. Now, the other thing that Spartan did, which is cool, and this is an evolving part of the story. So we showed great proteinuria reduction when sparsentan is used first line, but we're starting now to delve into the mechanistic components of it. So how is sparsentan working beyond hemodynamics? Because we've seen that there's suggestion for that both in our preclinical models and also from PROTECT. And so we're starting to look at biomarkers to see what exactly is going on. Now, one thing we see here is in the Spartan study, urinary SCD-163 was decreased, so that at week 24 was about a 50% reduction in urinary SCD-163. To take a step back, so urinary SCD-163 is a marker of activated macrophages. It was validated in the testing study. In testing where steroids were used to treat IgA nephropathy, they showed that if you got a 50% or more reduction in urinary SCD-163, that was associated with good long-term prognosis in IgA nephropathy. And so we're showing that data here, again, as the start of, what's going on, and to show that sparsentan potentially has some anti-inflammatory properties in the kidney without systemic immunosuppression. And that story continues here. We also looked at urinary BAFF and soluble C5b9. So recall, of course, BAFF is involved with B cell proliferation, maturation, and differentiation. And so obviously an important target and something that we're looking at when we look at activity of IgA nephropathy in the kidney. Soluble C5b9 is a terminal marker of the complement system. So again, marking complement activity in the kidney. And we see here, and I think it's somewhat surprising to also the investigators, is we see both BAFF and C5b9 being reduced. So by week 24, we see reductions of C5b9 at 68%, BAFF at 75%. These biomarkers not quite as far along as urinary SCD-163, but it begins to start that story of considering, well, does sparsentan have some anti-inflammatory properties by blocking endothelin? We know that endothelin is involved with inflammation, and so that blockade of endothelin here, are we starting to see some anti-inflammatory properties without systemic immunosuppression? Now, obviously, this is the beginning of a mechanistic story, and this is the start of a story which we're going to be able to continue at ASN this fall and on in some future conferences as we continue to look at this. But certainly an exciting finding and certainly thought-provoking to see how else may sparsentan be protecting the kidneys. Now, obviously, we want to show safety data from Spartan. And what we see here, I'll direct you to the right side first, we see a small decrease in blood pressure, but then relatively stable. So of the 12 patients that entered the study, 1 did have to discontinue due to hypotension, but otherwise, as a first-line therapy, well tolerated among the other 11. And you see some of the other side effects there on the left-hand side. So overall, we do see good proteinuria reduction when sparsentan is used first line. And if you go back to the KDIGO guidelines, the current recommendation is RAS or Odiara or sparsentan. And so we are an option for first-line therapy in countries where sparsentan is available. The urinary biomarkers start this story of a potential anti-inflammatory aspect of sparsentan that we're going to continue to dig into and think about as we try to show mechanistically how it's working to protect the kidney in IgA nephropathy. And before going to the panel, I did want to just briefly conclude and show some of our data with sparsentan and SGLT2 inhibitors. So we know that SGLT2 inhibitors have been a very important complement to what we're doing in multiple disease states, right? So not just IgA nephropathy, obviously starting with diabetic nephropathy and being applied to many other disease states. So we wanted to do a study showing, well, what happens when sparsentan is combined with an SGLT2 inhibitor? What kind of results do you get with regards to proteinuria reduction? So that's Spartacus. It's a phase 2 open label study of sparsentan. And so what happened, patients in the study were on RAS inhibition plus an SGLT2 inhibitor. When they were enrolled in the study, their RAS inhibitor was discontinued and they were placed on sparsentan and followed for up to 24 weeks. The SGLT2 inhibitor was, of course, continued throughout. Now, to be in this study, you had to have a UACR of greater than 0.3 grams per gram, and you had to have an eGFR greater than 25. So Protect took our eGFR 30 or greater. This brought it down a little bit more to kind of increase that criteria, because obviously we think those patients with CKD4 would also potentially benefit from sparsentan, especially in prolonging that time to dialysis. And what we see here, these data mirror very much what we saw in Protect and even what we saw in Spartan. So when you switch out your RAS and you put the patients on sparsentan, you again see that rapid and sustained reduction in proteinuria. So we're seeing that, we thought maybe RAS plus an SGLT2 may be the best I can do. Spartacus argues that if you're not at goal, you really need to consider, moving your RAS to sparsentan, because again, we're seeing really good proteinuria reductions, about 56% at 24 weeks. And of note, about a third of those patients did get a UACR less than 0.2 grams per gram. So we are getting these patients to complete remission more frequently, bringing that proteinuria level down. The other thing that we noticed is that it was well tolerated. So no new safety signals when we combined sparsentan with an SGLT2 inhibitor. And that was one of the primary reasons for this study, but showing it was well tolerated from a blood pressure standpoint and also well tolerated from a side effect and safety profile. And so again, replacing that max tolerated RAS with sparsentan did result in rapid and sustained albuminuria reduction, showing that using sparsentan in combination with an SGLT2 is certainly a reasonable option, or using sparsentan and adding an SGLT2 a reasonable option to get our patients to goal, again, with complete remission being an important target. Just kind of in summary, we walked through 3 studies there. The Protect study, our phase 3 study, showing sparsentan superiority to max label irbesartan with regards to proteinuria reduction and eGFR preservation. We showed Spartan, our mechanistic study, that showed an even better benefit when sparsentan was used early in first line, and also dove into the biomarker data a little bit, suggesting the anti-inflammatory properties of sparsentan that we've observed in preclinical models, and now we're going to start to bring forward more so in clinical models to explain sort of the mechanism of action of the drug. And then we concluded then with Spartacus showing the combination of sparsentan with an SGLT2 inhibitor was safe and effective in helping patients get to their proteinuria goals. That, I'd like to stop, and I will stop sharing and want to spend some time turning it over to the panel, so to Dr. Appel and Dr. Drexler. And so I think first question for both of you, and we'll start with Dr. Appel, is, now with all these options for IgA nephropathy, how are you thinking about sequencing and using therapies, with regards to the guidelines? What are your treatment goals and how are you achieving them? And we'll start with, like I said, with Dr. Appel.
Well, this is a challenging time because we have many new drugs approved, and they're being approved by lowering, at least by the FDA, for the lowering of proteinuria. That gives them the accelerated approval. And of course, we want to know the final approval. Drugs like sparsentan have also been shown to stabilize or improve GFR versus a comparator, and that's a major thing. So many of the patients come to me, they're already on an ACE inhibitor, ARB, and you tell them you're going to need multiple therapies to handle all parts of the situation here. It's a disease that has different factors going on. So the first thing I usually do is say, I'm going to maximize your supportive care. I'm just going to change one drug, and that is change their ARB or ACE inhibitor for sparsentan. I essentially am giving them 2 drugs that I know are both effective, that both have a good long-term outcome, and both are FDA approved for glomerular disease. So that's my first step in terms of that. Usually I'm limited by lowering the blood pressure in terms of that, but you could always add on a third at that point. But that's all acting on one part of the diagram, which is good. If there's inflammation, we may be acting on it. We don't have the evidence that lowering the urinary soluble CD163 is actually what's improving the long-term function yet in these patients. Hopefully it is, and you can act in a second place there in the same thing. But then I work on the glomerular inflammation and trying to knock out the basis of the disease, the immune complex, or the IgA galactose deficient IgA deficiency, and the immune complex deficiency. But I start basically right at the hemodynamic monitors in terms of the monitors that can work on the glomerular filters directly and easily and safely.
Yeah, because I'll jump in and add a bit more, and I agree. And then, Chris, that's a great question, and I certainly agree with everything Dr. Pella said. And again, we've seen in IgA nephropathy such an exciting paradigm shift, and particularly in the last several years, we've developed a better understanding of disease pathogenesis through the forehead model of IgA nephropathy. And I think what's exciting is that's allowed us to define the disease biologically, certainly, but also provides a clear rationale for using multiple therapies, multi-target therapies, to target the development of pathogenic galactose-deficient IgA1 containing immune complexes, but also all the downstream pathways that lead to progressive nephron loss and ultimately to kidney failure. And as we know, IgA nephropathy is challenging in part because it is quite heterogeneous. And as Chris pointed out, a majority of patients at diagnosis have CKD3 or even greater. So really, I mean, as a treatment goal, again, the guidelines, and I think we all agree, reducing proteinuria is extremely, extremely important, as we've seen with the RADAR data. I mean, 30% of patients, right, with time average proteinuria above a half a gram, but below a gram in that area, 30% of those, actually, I think even 20% of those with proteinuria below 0.5 will progress to kidney failure within 10 years. So it's not a benign disease, right? We need to really diagnose patients early, be very proactive about biopsying patients. My threshold is above a half a gram of proteinuria, unless there's some very other clear alternative diagnosis. And ultimately, we want to slow the rate of kidney function decline. And we see that, actually, Chris, as you showed, even with active control or in multiple clinical trials, including PROTECT, even with maximal supportive therapy, patients lose 4 to 6 ml per minute per year of GFR. So if we can bring proteinuria down, ideally below 0.3 grams per day, we can hopefully really slow the rate of eGFR loss to less than 1 ml a minute per year, which I think is really a key goal. And again, really, it should be a multi-target approach. I agree. I mean, I think we need to manage the IgAN-specific drivers of nephron loss, but all of the downstream pathways. And I think as we've seen, the data really more and more support a first-line approach with dual endothelin and angiotensin receptor antagonism to reduce proteinuria and slow GFR decline, but also all of this exciting data about hemodynamic effects, certainly, but also the anti-inflammatory and antifibrotic effects of the
one big question is that are all methods of reducing proteinuria the same in terms of what happens? And most people feel they're not. And, now drugs are approved for IgA, at least by the FDA in the United States, are approved for IgA nephropathy because they seem to be safe over a certain period of time and they've reduced the proteinuria. And that's one of the reasons that I rely upon the drugs that have FDA final approval, because they're showing that the bottom line is that the GFR is stabilized or improved over time. That you can't say that yet for those that have accelerated approval. There may be a certain usage for each of those, the newer ones that are coming out. The other thing is that the safety short term over 6 months or a period like that is not the same thing as safety over several years when you're showing that the GFR is better too. So the final approval is quite important here, but I'm happy that the FDA is doing things early. I mean, can move ahead right away with this.
Thanks for that perspective, Dr. Appel. And I see that we have a few questions in the Q&A as well. So we have a question about the process and how much time is needed in converting from ACEs and ARBs to sparsentan. Would one of you like to comment on what you do for that washout?
I don't use a long one. Chris, you can comment on what the studies show, but I don't use a significant long washout period. I mean, the only thing is I would say that, don't start with, 400 sparsentan right away if somebody's on a low dose of an ARB or an ACE inhibitor, because again, one of the things you don't want to have is hypotension, and you don't want to turn the patient off to your newer therapy when you're just starting, because you're going to have more challenges using blocking, the production of galactose deficient IgA, blocking the immune complexes, et cetera, and by blocking cytokines like in the very near future, like by blocking BAFF, in April. So given that, you want them to be in your camp and say, look, we're doing this without any significant side effects. And then you can adjust and titrate the dose.
Yeah, I take a similar approach. I don't use a significant major washout period. I switch over from the RAS inhibitor to the dual endothelin angiotensin receptor antagonist, and same approach as Dr. Pell. I do tend to start 200, make sure that it's well tolerated, and then increase to 400. And I think recognizing that for many patients, I think this is a foundational therapy and will be a lifelong therapy. So I think it's very important that they tolerate it, especially early on. And many do. I mean, as we've seen with the data in terms of blood pressure, very well tolerated. And that's been my experience as well. But certainly we need to, start
One thing
slowly.
about the new guidelines is that, the our 2025 KDIGO guidelines that talk about that the MESTC score of scoring does not tell you which specific drug to use, but it does tell you the category. It tells you if there's a lot of inflammation, then you're working on one thing. If it's mostly scarring, you're working on something else. I mean, this week we had a patient that, we said that the choice should be actually going from their ARB to sparsentan, that the insurance company said, well, we recommend iptacopan. Well, the person's biopsy had mostly scarring. It wasn't inflammation. And, then you're talking about somebody with much more to add on in terms of immunizations and following them carefully for, immune problems. So again, that'll be an easy one to fight the insurance company on. But again, this is going to be challenging because we already have new drugs. We have 2 new ones in the last year, and we're going to have a bunch more coming out very quickly. So again, look at the whole diagram. Look at the right side and the left side. And even the left side of the diagram has 2 different areas, blocking the immune complex formation and knocking out inflammation in the glomerulus.
And it'll be, I think the landscape will be even more exciting, but also complex, right? With the new B cell modulators that will be upcoming. So it is important. I mean, I think as we reach this time of having multiple therapeutic options, it's very exciting. But certainly, I think we need to understand better how to improve access and how to improve awareness and uptake of these very important treatments.
And so to follow up on, I think, a few questions on the chat. So first, so in PROTECT, there was no washout, right? So patients did go from RAS yesterday to sparsentan, very similar to the way Dr. Appel mentioned, with 200 milligrams, and then titrated up after 2 weeks as long as they were tolerating it. The other question in the chat was, were SGLT2 inhibitors used in the PROTECT study? And the answer to that was no, and that was because if you think about when PROTECT was done, that was sort of before the advent of using SGLT2 inhibitors so regularly. So they weren't used because really it wasn't a thing when PROTECT was being done, which is why we did Spartacus to kind of show how well sparsentan did work with SGLT2 inhibitors. Now, one other thing too, I think that we wanted to ask about, and I guess I'll start to, with Dr. Appel here, is when you're thinking about the importance of endothelin antagonism. One, how much did you all spend thinking about that and managing that? And now that we know more and we have endothelin options, how are you prioritizing endothelin blockade, and how are you choosing between, whether it be sparsentan, which is a dual endothelin angiotensin receptor antagonist, or atrasentan, which is just an endothelin antagonist alone? So I guess, how do you think about the importance of endothelin, and what drug are you choosing and why?
Well, I am not a big user of atrasentan at this time. Now, this doesn't mean things won't change in the future, but there are a couple of reasons. One, it again has gotten accelerated approval, which means it lowers proteinuria, but we don't have the long-term data on the GFR yet. the patients, when you say it's got accelerated approval, well, they say it must be better. It got accelerated approval, but it's not the final approval. So that's one issue there. The second thing is, each medication has certain different peculiarities, which sometimes don't come out for a certain period of time. There is some question about spermatogenesis with atrasentan. There's a question in terms of metabolism, in terms of that different genotypes will have different metabolism of the drug. So again, the longer it's around, the longer it's used, you'll get more and more information. Sparsentan has already had several years of usage already. I can tell you that, this is off-label. Wait a minute, am I allowed to say, yeah, I can say off-label. I mean, I use it for focal sclerosis patients, and especially those with genetic diseases and things that I can't use specific immunosuppression for. So again, we've got more and more, the more experience you get with the drug, the better it is to use that one. You'll get into less trouble. That's my feeling on it, but other people, like to try new things.
Yeah, no, I agree. I mean, I think endothelin blockade is very important in IgA nephropathy. Again, we know the endothelin system is activated, as you covered, Chris, and it mediates kidney injury. And it's not simply glomerular hemodynamics. There's also inflammation and fibrosis mediated by the endothelin system. That the data shows that sparsentan hopefully targets that as well. So again, it's not just glomerular hemodynamics. And then when we look at the data, it's really we see the benefit of dual endothelin and angiotensin blockade on reducing proteinuria and improving GFR slope beyond RAS inhibition alone. So I do view it as foundational therapy. As far as the decision on whether to use the dual endothelin angiotensin receptor antagonist sparsentan versus RAS inhibition and ERA, I mean, I do think it needs to be individualized. Certainly, it's important to have shared decision making with your patients. But I think, again, we should view it as with our patients. They're diagnosed early, often in their 20s, 30s, and 40s, and this will be lifelong therapy in many patients because we see that benefit at really preserving their kidney function and preventing or delaying GFR decline. So I think when we're looking at lifelong therapy, there's so much to be said for inhibiting endothelin and angiotensin with a single pill. It's very valuable, very practical for providers, for patients. And again, I think there might be some patients where we might want to uncouple the RAS inhibition and the endothelin antagonism, for example, if they have low baseline blood pressure. That said, though, in my experience, I think many of our patients, particularly those who are younger at the time of diagnosis, they can tolerate a lower blood pressure, and it's been well tolerated in the trials, including in the Spartan in terms of using this de novo, right, in incident patients. So I tend to go for the dual endothelin angiotensin receptor blockade for those reasons and for multiple reasons, but always important to have that discussion with our patients.
And I think, Yelena, you mentioned it, having one pill is very important because you're just switching that, because a lot of the patients you're going to at least think about adding SGLT2 inhibition, that, they each have their own certain advantages, and both ACE inhibitors, ARBs, and SGLT2 inhibitors have the cardiovascular protection as well. So adding on a third drug, but that's a third drug just on the right side of the diagram. You're going to be doing something on the left side of the diagram, and it's not easy to convince people, if they're young and healthy, that they're going to need several different drugs. It's one thing if they have a malignancy and you're an oncologist, or if you're treating myeloma and you say, I'm going to give them Cyborg and daratumumab because it has better survival of the patient. But now you're talking about survival of the kidney and maybe over 10 years. So again, getting two drugs that do all of it on one side is good, because you're going to be adding a third and maybe even a fourth on the other side.
And Dr. Drexler, so I think Dr. Appel brings up a good point there, and there's some questions in the Q&A as well there. Are you using dual therapy on everyone, so an immunosuppressive therapy plus a foundational or a kidney targeted therapy, or how are you making that decision, on how you're choosing and what you're treating each individual patient with?
Sure. Yeah, I think that is, an area where there's so much discussion. I think as in specialists in glomerular disease, we're constantly discussing this. It's a very rapidly evolving field. I mean, we've seen the new guidelines come out and already be outdated, honestly, when they came out, and we're anticipating that they'll continue to be iterations of these guidelines coming out, hopefully at a much more rapid pace. So again, I think we do need to consider multiple aspects of treatment simultaneously. Again, I think a big paradigm shift is doing both, right? On the left side, reducing or preventing immune complex formation and immune complex mediated injury. And then on the right side is managing the downstream consequences. So I think actually choosing between therapies that target the earlier hits, the left side of the diagram, is quite challenging, as I said, especially even now with B-cell modulators coming. So I do, again, we do rely on the biopsy, but we also have to recognize in these clinical trials, a lot of patients had biopsies a year or multiple years but previously, right? So we don't actually have clinical trial data on how specifically a biopsy should directly impact our care, but we still certainly look at it. I mean, as Dr. Pell earlier alluded to, if there's a lot of fibrosis, very little inflammation, I would really focus on the right side of the diagram with sparsentan, in my opinion, as foundational therapy and SGLT2 inhibition. And then in those patients who have more of an inflammatory phenotype, we need to do multi-targeted therapy, targeting both, again, the immune complex formation, and simultaneously, we have to recognize, even as we turn off immune complex formation with those therapies, whether it be targeted release budesonide or B-cell modulators, that takes time. And so simultaneously, we need to also include therapies that target the downstream pathways, the pro-inflammatory, pro-fibrotic pathways. And that's where, again, that dual endothelin angiotensin inhibition comes into play. So I think we need to be very actually proactive with our patients and really targeting, particularly though, for sure, that right side, and even as we do immunomodulatory therapy in certain patients. But it's challenging. I certainly don't, it's something that's we're really seeing a lot of changes. So in evolution in this field.
For the future, I think one of the most exciting things is those biomarkers that have recently been looked at. And I don't think that's been published yet, just presented at meetings, but showing that you can lower urinary soluble CD163, which has been studied a lot in ankylosing and in lupus as a marker for inflammation in the kidney. I mean, that's a product that's split off of macrophages in the kidney. That's the same thing, BAFF. I mean, like we've been using an anti-BAFF B-cell activating factor or B lymphocyte stimulator. It's the same thing, but we've been using one of those in lupus nephritis. Belimumab has been approved in the FDA for lupus since 2011 and last several years for lupus nephritis in terms of, again, blocking the inflammation. So again, we may be able to get more out of the dual blockade right now if all that data pans out. But I agree absolutely with Yelena here in terms of that the biopsy is the most helpful thing here. If there's a lot of inflammation, you have to keep that in mind and start working on it. We don't forget about prednisone and targeted release budesonide and even mycophenolate, which a lot of us use a lot in terms of this, just to keep the inflammation down, because otherwise they'll have turned off part of the process, but not the whole thing.
Thanks, Dr. Appel. So there were a few other questions in the chat just about sparsentan's approval and availability for different disease states. So currently the drug is approved for adults with IgA nephropathy. Now we are able to share that obviously we do have an application for approval in FSGS based off of our duplex data. So we will find out in early January, so January 13th, about the approval status for FSGS. Dr. Appel mentioned using it in some of his patients, already. We were recently informed by the FDA that it no longer requires an advisory committee for that approval. So we are hopeful, that we will have the opportunity come the beginning of next year to be able to bring the drug to patients with FSGS. And that will be extended, hopefully, even down into to children ages 8 and older based on the data that we have from our DUET and DUPLEX study. Other than that, there are no other disease states right now where sparsentan does have an active indication, but I did want to kind of mention those. So I think, with a few minutes left, maybe just kind of turn it over. And maybe we'll start with Dr. Drexler, just some final thoughts on, management and, just anything that you might think to help this group here listening in today. And then we'll turn to Dr. Appel for his as well.
Sure. Well, I think, again, we're in an extremely exciting time, exciting era in IgA nephropathy with new targeted therapies. But again, translating those advances into everyday practice, it's not straightforward. We still have challenges like access, cost, awareness, adoption. But we, I think, need to really identify patients early, look for proteinuria, hematuria, GFR decline, confirm that diagnosis with a biopsy, because it certainly has so much valuable information, but we need that biopsy diagnosis for patients to be able to access these new exciting therapies, and with many more in the pipeline. So, but ultimately, again, our goal is to reduce proteinuria as much as possible, to flatten that slope of GFR decline, and one of the very important aspects of that is the dual endothelin angiotensin receptor antagonism, as well as SGLT2 inhibitors. And so I think there's so much potential to improve the lives, the outcomes of our patients with IgA nephropathy.
I couldn't agree more. That was perfectly said. And I think the biggest challenge is going to be to convince people who feel healthy. And it was hard enough for their internist or their general practitioner to give them an ACE inhibitor, an ARB, that led them to understand that they still have proteinuria, but it's subclinical. They feel nothing from it. That proteinuria is a marker. So you can show them the data. I mean, if you have to, you can show them the International Kidney Disease Study tool in terms of just showing that for IgA that they're going to be progressive and they have to do more. If you can get them to do that and use multiple therapies at each step along the line, follow the biopsy, follow their course in terms of, again, long-term, it's going to make a major difference. So I'm very optimistic. This is a wonderful time for glomerular disease, whether it's lupus, C3 nephropathy, IgA especially. We're getting all these new drugs. For the clinician, it's more challenging, very challenging times, but we'll do it. We did it before.
So, on behalf of Travere, I do want to thank Dr. Drexler and Dr. Appel for the great conversation today. Thank you both so much for sharing your insights. And then also to Laurel and the ISGD, it's been a privilege for Travere to be able to work with you to help take care of these patients with glomerular disease. So looking forward to the continued partnership and appreciate your time today. And with that, I'll turn it back over to Laurel to close.
Thank you so much, Chris, and thank you, Elena. Thank you, Jerry, for joining us today. As always, a really thought-provoking and stimulating discussion. And I want to thank all the attendees too. And I wanted to also just acknowledge that ISGD truly is an international society. We have people here from all over the world, and that's a real privilege. And part of the work that we're doing is also on the policy and advocacy side and trying to make sure that our colleagues around the world can ultimately get access to these new and exciting treatments as well. So please know that, although we've been talking about sparsentan today and it's not approved everywhere yet, we have not forgotten about you all outside of the US, even though we happen to be based there. And again, thank you so much for joining us. Please do join ISGD. We will also be at the ASN conference. Please come and say hi, and we hope to see you again very soon.
Great. Thanks so much for having us.
Yes.
Thank you.